Yeah, thanks very much for inviting me. Nowadays everyone talks about personalized alignment, and I'd like to give you some insight about personalized alignment. So mechanical alignment is the good old times. The good old times, you exactly knew what to do, and you exactly knew what you get. You get a high satisfaction, you get a high durability of the implants, but the satisfaction rate is limited. So about 20% to 30% when you look at rheumatology literature are not satisfied. So I believe the time of mechanical alignment is over, and we need to look more into detail in personalized alignment. So let's look at these different alignment methodologies. Start with mechanical alignment. So mechanical alignment is quite easy, and this is why it has been chosen by INSAL, because it puts the femoral joint line and the proximal tibial joint line at 90 degrees, and at the end you end up with a straight knee. What you have to know is these four parameters. HKA is the hip-knee ankle angle, the FMA is the distal femoral angle, and the proximal tibial angle, TMA, and the joint line congruence angle. And when you get into this, you understand that the HKA is formed by the FMA, the TMA, and the opening angle of the joint. That's the joint line congruence angle. So why has it had been chosen at this time by INSAL? That's quite easy because we have seen a lot of these polyethylene diseases, and nowadays the polyethylene material has increased its quality, and so it's easy to go for different alignment methodologies. So this was the reason, and the reason is gone. So what about outcomes? Looking at outcomes of mechanical alignment, we see this study of Mark Pagnano, and you see 20 years follow-up, and there is no difference between mechanically aligned and other aligned methods, so that's pretty clear after 20 years. And there are other studies like ours. You see there is no outcome difference between mechanical alignment and non-mechanical alignment. And this is true for varus knees. If you look into valgus knees, that's not so true. So we shouldn't aim for a valgus orientation in valgus knees. So there, actually, the neutral alignment has some benefit, which has been shown in this study of our group. So why talk about personalized alignment? Because you have different knees. And you see patient A, patient B, that's quite easy to understand. It's 11 degrees of varus in both knees. So it's the same knee, is it? No, it's not. Then it's not the same knee because you look at the distal femoral angle, 95, and 88 on the other side, and you see the tibial angle is different and the rotation is different. So it's not the same knee. Why should we put it in the same position? With mechanical alignment, you put it 90-90 in both of these knees. The consequences are, I'm going to talk about this a little bit later. So this was the idea. So we have seen that we have different knees, and so we came up with this knee phenotype concept. And phenotyping means that you better look at these knees before operating. That means you have to look at alignment, morphology, and laxity when it comes to total knee arthroplasty. There are numerous publications from our group about this. You can read into this in more detail. So phenotyping in terms of coronal alignment means you look at these HKA, FMA, TMA, and then you form a phenotype as shown here. This has been presented. When you do so, you recognize that a lot of our knees are entirely different. And so this was a study done on normal knees, 300 normal CTs. They were analyzed in the way I've shown you. And we have done this on about 4,000 osteoarthritic knees, and then the differences are even wider. And so you need to understand that these knees are not the same. So when you start doing surgery on those, and let's start with the neutral phenotypes, that's quite easy because that should represent the mechanical alignment phenotype. So when you start with this, you see when you have a phenotype like this, which is present in about 5% of our patients, 5%, then with mechanical alignment, it's quite easy because this represents your phenotype and you don't have to do anything. So you see mechanical alignment, you do your bone cuts, and you're perfectly stable because the ligaments are the same and you don't change the alignment. With anatomic alignment, you do a little bit of change. Let's go for anatomic alignment phenotype. This is also present in about 3% of patients, so it's not a big group. So there, mechanical alignment, you need to do some ligament balancing to make, after bone cuts, you get your mechanical alignment stable. And then let's have another look at the other neutral phenotype. You see 96 degrees on the femur, 87 on the tibial side, some opening on 3 degrees. If you do so, you see this has a massive change with mechanical alignment. There is less change with anatomic alignment, and there is hardly any change when if you go for more personalized alignment, kinematic alignment. And we can go on like this. I can skip a little bit and then move to varus knees. And in the varus knees, it becomes even more evident that you need to think about your bone cuts. And if you go for mechanical alignment in this varus phenotype, you see 3 degrees orientation, valgus on the femoral side, 6 degrees on the tibial side for varus. Then with mechanical alignment, you need to do massive ligament balancing. If you want to do this, okay, but we are not good at doing ligament balancing because we don't understand what is really happening when we do all these procedures recommended by INSAL. So if you go for more personalized alignment, you hardly have to do any ligament balancing, and this is the case. So with mechanical alignment, what you do, you take all these phenotypes out of the box and you put this in the box shown here. So you change your bony alignment massively. And if you do change your bony alignment massively, that leads to the fact that you need to do more balancing on the ligament side, and we are not as good as we believe balancing these knees on the ligament side. So there are different alignment philosophies you have heard about. You see, these are the mechanical alignment, anatomical alignment. These are systematic alignment methodologies, and you have kinematic and restricted kinematic. And there is also functional. If you look at the phenotypes present in our population, you see mechanical alignment is represented by only 5%, anatomical 18%, restricted kinematic alignment 1/3 of the patient in the male group and half of the females. That shows we are not there yet, but we need to understand better what these phenotypes are. And this is why we came up with the safe zone concept to make a safe transition for a standardized systematic alignment to a more personalized alignment. And this is important to understand because we don't want to get into trouble to see 5-10 years following that there is a problem of durability. And that's why this change has to be done in a safe way. So how to find this optimal alignment? It's quite easy. You need to phenotype your distal femoral angle, your proximal tibial angle, and your HKA, and this gives you the phenotype. And while doing this, then you can decide what is the alignment methodology best representing this phenotype with less ligament balancing necessary, so which is more close to your bony anatomy. And this is restricted KA. You see the safe zone is a little bit bigger. Then you have inverted KA and inverted KA, and then you have more personalized alignment like shown here. This is Tibesco and Michel Bonin. And so you see these zones are becoming bigger, but at the end there are safe zones, and so we are still correcting some of the knees because we think that this is the safe way to go. With functional alignment, you also have a safe zone with functional alignment. A lot of people using robots talk about functional alignment. This is a combination of kinematic alignment and ligament balancing. The future will tell us if this is any different. Looking at outcome data, so this is a prospective randomized trial looking at kinematic alignment. You see that there is no difference in change of outcome scores between mechanical and kinematic alignment, and this is important to understand that not every study is showing a difference. If you look at like outcome scores looking at a longer term outcome, like this one here, 13 years outcome, there shows a slightly better satisfaction, so the function is better, but there are no difference in PROMs. And when we look at kinematic alignment studies here, comparing mechanical and kinematic alignment, you see that with kinematic alignment, this is not the proper solution yet, because you see that you put some of your knees in internal rotation on the femoral side, and this internal rotation then might cause patellar problems. And this is why the functional alignment guys tell you, okay, this is probably not the pure way to go. Kinematic alignment is good for balancing the extension gap, but the flexion gap is much more variable. We have done some studies together with Heiko Greichen looking at the laxity of the joints. That means the envelope of laxity. And we've seen there that the extension gap is rather predictable, but the flexion gap is all over the place. And that shows this study, also from Sebastian Lustig, that it's very hard to balance the flexion gap. And if you are a pure measured resection guy, as most of the kinematic alignment guys are, then this is a problem, and this is where probably the benefit of the functional alignment comes into play. At the moment, we don't really know what is the perfect personalized alignment, but what I like to highlight here is that you have to phenotype your knees, and you have to phenotype your knees to better understand what is the preferred alignment methodology. At the moment, there is not one preferred method I can recommend here from this perfect. So looking at these examples here, you see preoperatively phenotyped knees, so that's marked in red, and then the correction goes into the constitutional alignment, and this is where to go. We are much wider in the safe zone than mechanical alignment, so the changes you have to make while doing ligament balancing are less big with the personalized alignment, and I think that's an important message to do. When I started as a resident, it was the time where we had to do a massive release on the medial side for every varus knee to make this knee straight, and this time is gone. Most of the people doing less releases, and that's important to understand. But it has to be like a careful process. We need to do it meticulous, so you need to start phenotyping your knee based on your long leg radiographs. You can analyze the hip knee ankle angle, the distal femoral angle, and the proximal tibial angle, and then also measure the joint line congruence angle, because this gives you an idea about opening of the joint. So then you can pre-plan your bone cuts and also the amount of ligament balancing necessary. I think it's important that you need to have this phenotype information, and then we can proceed to a more personalized alignment. So this is an example I've seen because I'm a reference center for painful knee arthroplasty, so I get a lot of referrals, and in my clinic we would have done a uni in this case, following the discussion we had before. But so she went elsewhere after our, got a second opinion, and they did something like this, and they claimed to do kinematic alignment, but actually that's just a surgical error. So we cannot say this is all personalized alignment. This is not personalized because the orientation on the tibial side marked like from a slightly varus knee into massive varus, and this causes a lot of problem to the patient. She had a flexion of 30 degrees. You see the low riding patella, the femoral component is too flexed, and so this is not kinematic alignment. So if you want to go and start with personalized alignment, you shouldn't only have good intentions, but you also should have a good knowledge about what you do. And this is an important key message to give, because nowadays at some of these conferences you hear, now personalized alignment is the way to go. No, it's not. You can start and you be more personalized in what you do, but still you start from mechanical alignment and then think, what do you do with your bone cuts? How can you make it more personalized? For us, it's important to stay within the safe zone. My safe zone for conventional total knee arthroplasty is 3 degrees orientation varus on the tibial side, no valgus on the tibial side, and then on the femoral side, I think it's acceptable to go to 5 degrees, makes up a varus of 3 to 5 degrees on the HKA, and that's important to stay in this envelope to be safe for our patients. That's the sake we should aim for. So if you want to read more about this, you can read in this book. And I also like to invite you to Basel. Basel is a very nice place in Switzerland. It's very calm and quiet in comparison to Cairo, because I had the pleasure to be taken out into Cairo street, and that's much more overcrowded here. And so I had recently a guy from India visiting. He told me, Michael, what's wrong in Basel? I said, no, everything is okay. It's rush hour. And he said, no, there is no one on the street. There is no one on the street. And that's Switzerland. If you want to have some quiet, come to Switzerland. Thank you very much.